and it's my great pleasure to be your moderator for today's session that we are co-hosting with the Department of Community Health Sciences. Next slide. I would like to begin by acknowledging the traditional territories of the people of the Treaty 7 region in southern Alberta, which includes the Blackfoot Confederacy, comprising the Siksika, the Kainai, and Kainai First Nations, as well as the Tsuut'ina First Nation and the Stoney Nakoda, including the Chiniki, Bearspaw, and Wellesley First Nations. We also want to acknowledge that the City of Calgary is home to the Métis Nation of Alberta, Region 3. For today's session, I just want to start off with a few housekeeping reminders. For attendees, we will be having a Q&A session at the end of our seminar today. So please just ask your questions via Q&A box that you have at the bottom of your screen. You can also email your questions to iph@ucalgary.ca following the session. I would also like to point out that we've already received some questions to our email address, and we will try to answer those questions in addition to the ones that we've already received in the Q&A. I also want to say that this webinar is being recorded and it will be posted to the O'Brien Institute's website following the event. In addition, I also want to mention that we will also be trying to answer any questions that have not been answered during the Q&A session, and that we will post those answers on our website. So I'll begin now with the introduction of our presenters. It's my great pleasure to be able to introduce Dr. John Connolly. He's a professor and former head of the Department of Medicine at the University of Calgary and Alberta Health Services. He's an infectious disease specialist with medical training who's held several leadership roles with the Canadian Infectious Disease Society, the Canadian Committee on Antibiotic Resistance, the Canadian Expert Drug Advisory Committee, CIHR's Institute of Infection and Immunities Institute Advisory Board, and the WHO's Advisory Group on Integrated Surveillance of Antimicrobial Resistance. He's currently the chair of the WHO's Infection Prevention and Control Research and Development Expert Group on COVID-19 and a member of the Canadian Expert Advisory Group on Antimicrobial Resistance. He's received many career awards in areas of research, teaching, service, including the Ronald Christie Award for Contributions to Academic Medicine in Canada, the Medal for Distinguished Service from the Alberta Medical Association, and last but not least, the Order of Canada. He's an active consultant in clinical infectious diseases with current research interests focused on antimicrobial resistance and stewardship, prevention of hospital-acquired infections, and novel innovations in healthcare. Our next speaker to introduce is Dr. David Fissman. He's a professor of epidemiology at the University of Toronto and a fellow of CIHR's College of Reviewers. He's a physician epidemiologist with research interests that fall at the intersection of applied epidemiology, mathematical modeling, and applied health economics. He completed a residency in internal medicine at McGill University and Brown University before completing a fellowship at the Beth Israel Deaconess Medical Center in Boston and an MPH at Harvard School of Public Health. He is an AHRQ Fellow in Health Policy at Harvard Center for Risk Analysis and has held faculty appointments at McMaster University, Princeton, and Drexel Universities. He develops and applies novel methods that allow physicians and public health experts make the best possible decisions around communicable disease control using the best available data, and has been a recipient of CIHR funding for the study of COVID-19 epidemiology. And our final speaker, or will actually be our first speaker, is Dr. Kim Prather. She's a professor and distinguished chair in atmospheric chemistry at Scripps Institution of Oceanography at UC San Diego. She's the founding director of the NSF Center for Aerosol Impacts on Chemistry of the Environment. She's published over 220 papers detailing how aerosols influence the atmosphere, climate, and human health. She holds several patents on innovative technologies for measuring atmospheric aerosols, including an aircraft-based aerosol time-of-flight mass spectrometer instrument that has been flown through clouds to study how different aerosol sources affect clouds and precipitation processes. She's an elected member of the National Academy of Sciences, the National Academy of Engineering, and an elected fellow of the American Geophysical Union the American Association for the Advancement of Science, and the American Academy of Arts and Sciences. So now I'll hand over the talk to Dr. Prather, who will begin the discussion, to be followed by Dr. Fissman, and finally with Dr. Conley, and then we'll have the Q&A. Thank you very much.
Okay, well, thank you for that introduction. I just want to make sure I can share my screen. Is it sharing? I think it should be up there now. Okay, can everybody see my screen?
Yes, that's perfect.
Thank you. All right, well, thank you. I'd first like to thank University of Calgary and the O'Brien Institute for organizing this discussion today. Since I'm starting, I thought I would just sort of remind everyone about what the topic that we were given to discuss is, and it's about, oops, I just pushed the wrong button, sorry about that. This ping is in my way, sorry. I guess I'll just make it up. But basically, we're discussing whether airborne transmission is an important and mitigatable aspect of the COVID-19 pandemic. And so what I'm going to start out with is presenting about the evidence that supports, yes, indeed, it is airborne transmission is, in fact, a predominant mode of transport. And I'll say up front that we're not, I'm not going to say that it's 100%, but it can be quite significant. And today I'll talk about why that is the case and the evidence that supports that. And the answer to the mitigatable aspect is yes, it is. Once we all acknowledge that it is airborne. So this slide probably has the most importance of anything I'm going to talk about. I could spend the whole 10 minutes on this, but basically this is kind of a artist's rendition of the view of sort of how people produce aerosols and droplets. And this is actually based, I'm an aerosol scientist by training, this is based on physical measurements. And so, basically what we see here is that when people are just simply, singing, talking, breathing, they're aerosol producers. And that's something that's become a big, obvious part of this pandemic. And I'll talk more about that. In other words, they don't have to be coughing and sneezing. They don't have to have symptoms. And so one of the major ways this virus has snuck its way around the globe is that it can be largely spread by people who don't know they're sick. So they're not coughing and singing or sneezing, they're just out in the public talking to people. And so basically what happens is, you produce, when you speak louder, you produce more, but when you speak, you produce aerosols. Little tiny aerosols that come out, lots of those, thousands of those come out of your mouth continuously while you're talking. And those will float in the air. And if you're indoors, they can float in the air. They can go much further than 6 feet, or basically they can build up in the room, just like, think about cigarette smoke. They basically are of that size and they behave visually very similarly. You also produce some number of very few, I would say, just when you're speaking, you produce many fewer large drops. And this is defined, I'm going to talk about bigger than 100 microns, because these follow a very different aerodynamic pathway. And you can see it in this figure. They basically are immediately falling to the ground, and they will fall to the ground, most of them, within 6 feet. If you're unlucky and you're standing too close, these could hit your eyes, nose, or mouth. But basically, as you can just see from this picture, and this is the thing that I will talk a lot about, that the greatest chance you have of being infected by this virus is inhaling this virus at close distance. So let me just go through the pathways. You can do short range inhalation just based on pure number, based on physical measurements. This is the most likely pathway. Long range, it becomes more important, but it's much more dilute. And so this is what the public health community has referred to as airborne, but I'm just gonna call it long range inhalation because that's more related to how we can fix it. And then there's the droplet spray, and this is not, above 100 microns is not gonna be inhaled, as I already mentioned. And so aerosols float and droplets drop. All right, so what is the evidence that we have? Well, basically, let me start with the public health community has pushed or said that you don't get aerosols unless you're doing, and we don't protect against aerosols unless you're doing aerosol generating medical procedures. And one of the big things that's come out of this massive amount of research that has been done, which I'm trying to capture, as I mentioned, in 10 minutes, is that this basically people are aerosol generating people, AGPs. And so, and more importantly, I think a big part, as I say, the way this virus has stealthily made its way around is you produce aerosols all the time, but you're more infectious and you're producing potentially more aerosols before you have any symptoms, without any symptoms. And so this has been shown in a number of ways, and I think it's something we've come to really appreciate, and the evidence on this is just growing and growing over time. So you get short range inhalation, as I mentioned. So then the question became, do we see it in the air? And the answer is yes. It's really, really hard to sample viruses from the air because there's so few, and you sort of destroy them when you sample them unless you use special methods. And that was used by Lednicki to sample these viruses in a very delicate way so that you could actually culture them from air. So we've checked, I think, all the boxes, on the fact that this virus definitely can be airborne. There's also long-range inhalation, and that leads me into my next slide. So the main pathways, I say I'm going to sort of support the airborne aspect of this. And the biggest piece of evidence that we have are these thousands of super spreader events. And they all take into account, indoors, low ventilation, no poor mask use, long durations of exposure in crowds where people are talking, yelling, and singing and not wearing masks. So you know what those areas are. So there's many examples of gym outbreaks. There's choir practice. There's a famous choir practice that we've all heard about. There's also restaurants, and this just came out within the last week. This is just showing one infected person in a restaurant. They've modeled all the dynamics. They measured the flows, and they found out that there was a pocket of air that was trapped at this end of the restaurant. So all three families at this end of the restaurant got sick. There was video that showed they never interacted or never came within 6 feet of each. A lot of them didn't come within 6 feet of each other. So this is a great example of what happens in an indoor environment. One that just came out in the CDC EID journal is this one, which is basically an outbreak at a big church where a chorist turned out he was sick, sang 3 days, infected people over 2. So he sat here 10 feet above the crowd, and these people were more than 50 feet away from him, and they all became infected just in this one part of this massive church, which turned out it didn't have hardly any ventilation. People weren't wearing masks. They used video to show that the chorus never interacted with the people, so there's no contact. There's no droplets either because the chorus had his back to the people that got infected. So droplets don't shoot out and then turn around and go back. So this is a great example of something where airborne has to be invoked. And finally, sometimes some of these real world situations are difficult to sort out through the epidemiology because there's so many factors. So then there's these animal studies where you can they put ferrets in cages, they pushed air. Basically this little guy was infected, and there's 4 90-degree bends. Droplets don't do bends. And so only aerosols can make it all the way up. And in fact, the one on the top got infected. Again, another example of no contact, and it's not droplets. So what about these AGMPs? So there's a paper that just came out by Wilson et al., and this is an adapted figure from that. And basically what you see is the number of aerosols that are produced by a particular respiratory activity versus just breathing. And you see there's an enhancement from talking. There's more if you're exercising. There's more if you're shouting. There's even more if you're coughing, up to 371 times more than if you're just breathing. Compare that to AGMPs. You can see right away where the conundrum lies. There's barely any AGMPs that are coming out during the things where people are, in this case, being offered and told to wear N95 masks. They're saying use airborne precautions. In the case where the aerosols are actually coming out and it actually is airborne, many of them are being given mostly surgical masks. And so the number of reports of people being infected with these surgical masks is just taking off, unfortunately. And so, basically this is something that needs to be addressed, and we hope it will be soon. All right, so I hear this all the time, droplets versus aerosols. Why do you care? You just want to say aerosols because you're an aerosol scientist. That's not it. Basically, why does acknowledging airborne matter? It matters because the things that we put in place for droplet precautions, both in terms of masks as well as controls to clean the air, they do not fully protect us or anyone against aerosol transmission. So let's think back to July. We wrote a letter, many of us, 239 experts wrote a letter to WHO saying it's airborne, please acknowledge that it's airborne. And at that time, WHO came back with a scientific brief, which said, this is just a few of the things that they were asking for. If we're going to say aerosols are coming out, we need to prove that it's coming from people. That has been shown over and over. If we're going to say that